Welcome, my friends, to the Bob and Brad podcast. My name is Mike Keenitz, and I'm a PT assistant. Today, I am interviewing RT Hill and Niraj Vora from the Stride Shop. Both are physical therapists, and they own a running clinic in Baton Rouge and New Orleans, Louisiana. So we are going to talk about different running injuries and how to work through them and different exercises you can try to fix these problems. So without further ado, here are the gentlemen from the Stride Shop. All right, let's get, since we have been talking about hip pain now, we'll get on to the hip pain subject. So what approach, we'll say lateral hip pain, because if someone has like groin pain, that's the hip sockets. We'll say outside hip pain. So what approach do you guys use? I'm assuming it's kind of similar to what we're talking about for IT band.
Similar. First, ruling out a stress fracture, right? You want to talk about high risk areas that if you've got a stress fracture in the area, it needs to be addressed quickly, right? So I think first thing I'm doing there is trying to rule that out. So that subjective evaluation, that subjective data that you're bringing in, is, you can't put a price on it. It's so important when it comes to lateral hip pain kind of stuff. Say that all goes well and you clear that out, then it's a matter of going through, the exams that you learn as a student in PT school, and some stuff that you pick up along the way, which is, what is your hip range of motion, internal to external rotation ratios, or total hip range of motion, and then has that hip and has that tissue been stressed in each of those planes, right? You may have a really strong glute max, but if I ask you to get into a side plank, you can't hold it for more than 2 seconds, right? So super strong in one direction, but you have no ability to stabilize in this plane right here, right? So then it's a matter of, well, let's find a way to progressively load that tissue if it's muscular related, and build up that resiliency so that it can tolerate longer runs and faster runs and different surfaces that you're running on. That's if it's from a muscular standpoint. A little bit different if you're dealing with like a FAI or like a labral tear or something like that. But still, then again, goal is probably going to be initially, let's stabilize the hell out of the entire joint and go at it from that approach.
So you guys do more like isometric strengthening with hip abductor stuff then?
RT does a good bit more than I do, and I think it's really effective. I don't know why I haven't picked up on it as much. But, RT does a good bit. When you talk about lateral hip pain, I think what you had mentioned earlier was also kind of this glute med or glute min tendinopathy at the lateral hip. And so, yes, of course, the subjective history is, like RT said, is gold. I mean, you can't shortcut that. And when it comes to rehab, you also can't forget some of the things that we talked about before, like this crossover gait may be a factor. I've spoken with people who are like, I sit all day, and they sit with their legs crossed, right? So you go out and run, and you train, and you do the right things. You side plank, you do your lateral step down and all these things, and then you sit for 6 hours with your leg crossed, and you're just kind of pulling at that tendinopathy and serving to just make it sensitive and irritated, right? So little things may matter too, but I think what RT talked about is loading that tissue. We know that tendinopathies, tendinitis, what you may call it, respond really well to us challenging the tissue. So whether that be by starting with side-lying hip abduction and then moving into a standing hip abduction, and then a standing hip abduction with some resistance, and then lateral walking with a band or a lateral toe tap, and then into a side plank. You have to progressively load that tendon. And also, when you think it's good, that's when you've got 2 or 3 more months of work to do, right? Because as we know, as soon as it starts to feel good, all of us stop doing what got us there. And the nature of tendon is not that it has, it hasn't restored its normal properties. We know that the collagen being a major player is degraded a bit when you start to experience those symptoms. So I think setting expectations is something that we try to do well. Is that, look, I'm gonna, maybe we'll get you to where you're running the volume and intensity that you want, but I'm going to see you back in this clinic in 3 months if you think that you're going to stop doing your exercises and be okay, because lateral hip pain, tendon-related lateral hip pain takes a lot of work.
Yeah, I would say it's annoying because it never hurts you when you're doing the exercises or the running. It's that night when it hurts, when you're trying to go to bed. And it's just like, oh, I overdid it. And then I think I'm good. And I try to do something harder. And then I'm back to square one for like a week.
Yeah. I mean, tendon pain is very much of that nature too, right? You have 3 good days and then all of a sudden you're hurting and you don't know that you did anything different. And I don't know that there's a great explanation for those. I'd be making it up if I said it, but I think that's just the nature of tendon rehab, is that it's very up and down. The trend should be that it's getting better if you're doing the right things, but you're still going to have those days where you just are pissed off because it hurts, and you don't know why.
Do you guys depending upon someone's, if they're anteverted versus retroverted, meaning for our listeners, the way their femur sits in their hip sockets, if it's forward or backwards, do you guys look at their gait and just kind of let them do what they naturally want to do with that, or do you try to change it?
Yeah, I think that there are lots of things that we don't know about the hip, but what we do know is that anatomy can be very different from person to person, and even within, Mike, you may have 2 very differently shaped hips, the acetabulum and the size of your femoral head, and the angle of your femoral neck may be different from one side to the other. So when we see people with, kind of this windswept pattern where like both feet are turning one way or the other way when they're running, or they're very toed out or something like that, the inclination may be, well, that just looks weird. Let's get it straightened out. And I think that's probably one of the last cues that I'm going to use as a Hail Mary if nothing else works. I think that people kind of selectively move into these patterns based on their anatomy in a lot of ways. And we're not going to change your anatomy. So we probably just create problems if we try to, quote unquote, straighten you out.
Yeah, when I was in PT school or PTA school, I was taught, you should walk with your toes ahead, and I'm naturally somewhat retroverted.
Yeah.
And so I started running that way later on, and then I'm like, now I have these injuries, and I was talking to PT, and he's like, why are you putting your toes straight? He's like, you sit down, you're retroverted. He's like, quit walking straight. He's like, you're screwing up your own anatomy. And I was like, oh, it's like I never thought about this.
That's one of those things you have to respect and be aware of too whenever someone's lifting, right?
Yeah.
Weight training as well, like you were saying, right? You're not going to go in and that you have this much more open space to get into a deep squat when your feet are pointed out a little bit. So talking about for you personally, you're not toeing in whenever you're getting in there and squatting, because then you're just kind of jamming in on that joint, right?
Yeah. So
that's about the only time where I'm making active suggestions on kind of foot placement and angles and stuff like that. But for running form, rarely am I changing the form necessarily. I'm letting that be a result of the mobility and the strength training that we're doing, and kind of letting the running form fall in line afterwards.
Okay. Well, do you guys have anything else to add on hip pain?
It's kind of those giant broad ones that we could probably sit here and do a long talk on a lot of different diagnoses on it, but no, not in particular. I think we've hit on it time and time again, is that subjective history is such an important thing when it comes to running related injury, and honestly any kind of rehab in general, because a lot of times the pain that you're having in one place is a result of something that's happening someplace else, that a lot of times that patient or client has kind of disregarded as a secondhand thing, but is a really valuable piece of information that needs to be addressed and needs to be fixed in order to unravel kind of that entire knot that's causing the issue that they're having at the time.
Sure. You guys want to mention your website and where people can find you on social media quick before we get too in depth here?
Sure. Our website is thestrideshop.com. We've got blogs and some free resources and a newsletter that we think is cool. And we've also got an online course called video series called Building a Resilient Runner that we think stuffs a ton of information into some 10-minute segments that can be helpful for runners of all abilities. And then social media, we are at The Stride Shop on Instagram and The Stride Shop on Facebook.